Welcome to today's session, and I don't see Boyd, but I want to thank UT and President Boyd for having the vision of gathering all these people, and of course, President Nolan from ETSU as well, um, and for this opportunity to talk to you this morning. So these are my notes. I'm going to use my laptop as my So actually what I want to start with this morning is kind of to get us thinking. That was off. Okay, minor details. So I want to just kind of get our mindset the rest of this talk. So we'll what it is, and I would encourage you haven't really struck me because filmed and focused in Nashville half of my life now, but it really talks about really is a great video. So collaborative. Sorry. Can you hear me now? Sorry. And so it's called One Tennessee. And what we're really aiming for is working together within healthcare as one voice, and then coming outside of our sector and working with other sectors collaboratively. And really what that takes is each sector to kind of come together themselves, which is part of what we've tried to arrange for you today, to really talk about your unique problems that you understand in the sector and begin problem solving how you may be able to work with other sectors. That's really the end takeaway goal from today, is to begin those collaborative relationships at a community level. And so we'll talk about that collaborative piece in it. So we're aiming to save lives. We're aiming to prevent addiction, stigma, and improve the wellness overall of the people at Tennessee. For us, a focus on the healthcare piece has improved practices, avoiding the unintended consequences of overuse, and not really looking at the proper use. So just a little bit, you've heard actually a little bit about story. And so how does someone who spent 30 years from grad nursing student 1 year ago. The hospital. I spent my life trying to get babies from this point with all of this equipment live and teams live to a place where we could look at the happy part of things. Grow and see them go home and happy families and be able to move off onto their best foot. So as Joe Sloan said, it actually started in about 2009. Up to that point, my first experience as a new grad the first year was not really a baby that was in withdrawal, but a baby who had been very premature. Mother had just, and that causes problems with the vasculature. And what happened was the mother abrupted, which means we're away, lots of bleeding, mom and baby can both die. And they had put her, this was in South Carolina at that point in time, they put her in jail when she got out of the hospital. So this baby had nobody, this mom had nobody, no family, nobody coming to visit this baby. The baby was extremely sick. And so it came the point where we knew the baby wasn't going to make it. And there was nobody there. And so this was my primary patient. So as a new grad, learning all of this, I held that baby while it died. And I thought, what a terrible thing. And thought that was back when I thought this was going to be a big surge. And there were, but it wasn't. So my career kind of went on and just kept doing the thing, and got involved in some quality improvement projects that had been successful, and so built relationships within the hospital and institution. And then we started seeing in 2008-9 an increase for babies that were coming from hospital that were withdrawn. And our practice also saw newborn babies, so my newborn rounds, I was seeing babies who were looking very different than the other newborn babies. And problems, and for those who don't know, NAS or neoadolescent syndrome, also known as NOWS, neonatal withdrawal, very different. They're irritable, they're very rigid, very uncontrollable. Diarrhea, skin. These are just a few experiences. And so we're admitting more and more and more of these babies. And, what do you do? I wasn't taught how to do this. I went to my neonatologist. They weren't taught how to do this. There very little in the literature, very, very old, on how to treat, actually to the point one of the treatments. And so the families were very, very had moms that different states process. So it was very challenging. A lot of guilt that was behind where they were, and so there was a lot of anger, and it was very different than the usual situation we have with our families. So I ran from them. Most of us ran from them. We let the physicians deal with them. They always want to end up talking to the physicians and argue, so we'll just let the physicians deal with it. And it started to get so pervasive that it just wasn't that wasn't an option anymore. And one morning I came into work and I was walking down the hallway at 8 o'clock. So the nurses got there, started at 7:30, 7 o'clock. And I was met by one of the nurses. She was holding a baby that was crying. She was breaking a sweat already. She had tears running down her face. And she stopped me dead in the hall and said, somebody has to do something. And I can remember that moment. It was one moment in time. And I took a deep breath, and I thought, oh, gosh, she's talking to me. Oh, okay. I don't know what we're going to do, but okay, I hear you. And so I gathered. I went to the hospital administration. Sherry Smith was a nursing administrator at the time who worked in the NICU and had been the administrative arm of other quality improvement projects. I went to her. We went to the next people that we had worked with, and we kind of started another task force, and we started looking at this. And what we found was at that time there was very little literature. There was no evidence-based practice. Everybody was treating these patients differently. And so we had nothing really to go from. So we just started, and it was all hands on deck. Every person at the table took their expertise area and researched it and looked for what they could find that made sense or might be evidence-based. And we came back together and we started, putting a protocol together. From the beginning, we felt like we wanted to look at ways to avoid using medication. So that was where we started. We wanted to look at a holistic approach and what can we do before we give medication or instead of giving medication. And then we took a quality improvement approach to it, and we took cycles. We call PDSA cycles that we tried an intervention, and then we looked at the outcomes, and then we adjusted. And over a course of several years, we ended up coming up with a pretty tight protocol that worked for us. And so if you look at this graphic, I just wanted to give you kind of an update. You saw a lot of statistics yesterday about NAS, and yes, we are seeing at least a teeny little downtick in it, but about right now, about every 15 minutes, a baby's being born that's suffering from withdrawal, and that's pretty impressive. I remember at one point in time watching the signs on the highway for the motor vehicle deaths, and I was also tracking the NAS reporting, and they were 1 and 1, almost exactly. And so I thought that was a pretty interesting marker as well. So in babies who are exposed in utero, approximately 54 to 96% will experience withdrawal enough to require intervention. It can vary in severity and time of onset. It's very dependent on differences in medications or drugs that the mom is taking, the timing of them, her metabolism, baby's metabolism. It's very, very complicated, and people are trying to do work to tweak all this out, but it's very, very difficult to weed all those things out. Of interest, we are discovering now is research to show what we kind of were experiencing at the time, which is a higher admission rate for these children. Just even during the first month of life, but now we know that they have a much higher interface with the medical system during their first year of life as well. So it's not just that it's emotional and difficult for these babies to go through, it's also very costly to our healthcare system. We had to expand our nursery by 16 beds because we didn't have enough beds for all of the other infants we were taking care of. And so that was a big percentage. So what's really interesting as well is the course of my mindset and how I came around to being here talking about this from a place of running from these babies. And one of the things that I really started to find out in talking to these moms was that most of these women weren't intending on getting pregnant. They were either, any number of things. Some were in recovery and they had a relapse and they got pregnant during their relapse because they were trying to get drugs and they had sex. And here they were with a baby. Some were just in active addiction and weren't doing anything to worry about birth control. Many of them thought there was no way they could have a baby based on the drugs that they were doing. And some were on replacement therapy. At that time was replacement therapy. And were having babies that were experiencing withdrawal from that. So it's really kind of staggering because this is a great opportunity here for improvement. And, if you have 86% of the opioid-using women who are having unintended pregnancies, it's a real easy way to prevent NAS. And people used to get upset when I said NAS is 100% preventable. If an infant is not exposed, it will not have NAS. That doesn't mean that I'm judging how the mom should be taken care of at all. What it means is that it is preventable and that many of these women are not in a situation where they can have access to long-acting reversible contraception, and given a choice, education and a choice, many of them would prefer that. And then they can get on the road to recovery and not have it railroaded by an unintended pregnancy and all that ends up coming with that. They're less likely to have good prenatal care or prenatal counseling, and so that also affects the outcomes of these infants in general. It puts them at greater risk for all kinds of other problems from their pregnancy and makes those infants very, very high risk. We did see during the time, I think the last thing here is that this was a study, national survey on health that at that time showed that 60% of the women who were using in the past month prior to delivery had used cocaine as well. And it was interesting because we did see that there was an uptick in the amount of cocaine that we were seeing in these moms. And again, it kind of dipped a little bit, and now we're seeing a resurgence in cocaine and methamphetamine. We also saw a really high, alarmingly high incidence of moms with hepatitis C. And this is really important for the infant because it's a vertical transmission potentially to that infant directly from mom to the baby. But you can't test these babies for it at birth. They can't be tested until they're about 18 to 24 months. There are some improved testing techniques that are coming about, but it's not something that necessarily can be done at the point that they're in the hospital. Therefore, if there isn't good follow-up, if we aren't really tending to the situation at home and educating pediatricians that they need to be screening for the possibility that this child should, because it's not a universal test, not everybody gets it, then these infants can go without being tested and undiagnosed. Undiagnosed hepatitis C can lead to many, many health complications, and really untreated can lead to liver problems and need for liver transplants. So it really felt like we were just navigating this sea of icebergs, really. We were just in this rocky place, and all these different things kept popping up. Oh my gosh, there's this aspect, it's bigger than this, and it's bigger than this. And so we moved all the way upstream and really looked at that this is about the substance use problem in the United States, not just opioids, but the substance use problem in the United States and the impact that's having on families in general. And so, when you look at it, we always said it was like the tip of the iceberg, right? And so if from a cultural perspective, about 10% of it was what we could do, what we saw from the medical care, from the institution kind of standpoint, from the systems. And the rest of it is really all cultural, and it comes back to stigma. And the ability for these women to access care, the desire for them to access care, to reach out for help, the shame that they feel, the judgment that they feel they will get, that they have gotten, makes a very big difference in how they proceed, with their care. One of the first things that I had to realize in this process was that I was part of the problem. And this hit me when I had a conversation with a mom who had a 15-year-old. She looked every part of what I would, in my judgmental mind, had come to decide this was a typical mom in this situation. Much younger than she looked, missing some teeth, not in a great state of health. And she came in, I went in to introduce myself, and man, she was fired up. She was ready for everything she thought I was gonna throw at her. And by this point, I had had many, many conversations, and I listened to her. And I heard her story. She said, I had a 15-year-old who was a perfect pregnancy, and this isn't who I was then. And he's had to watch me go through getting addicted to pain medication, post C-section, and my struggle with that over this past 15 years to where she is a heroin user. And she was very worried about her baby, and she asked me about seizures, and I said, it's 5 days, we're probably out of the woods. I think we'll be okay with that. And we talked, she disarmed, she left. She was at that point, in a residential abstinence-based program. And she was walking down the hallway, and I turned and looked at her baby. I was talking to the nurse, and I looked down, and her baby was seizing. So I had to run down the hall and get her and bring her back in. And we ended up with a very high level of trust between us because of the fact that I listened to her. And that mom brought breast milk into that baby every single day during his hospitalization. If she couldn't make it, someone from the house brought the milk. She was going to court. She had a great support system at this point in time, but the judge felt she needed to really prove that she was going to be a year clean before she could have her baby back. So she was devastated, and I was worried because we just took her motivation away from her. And I thought, well, that was me. I'd turn right back around to what was getting me through every day. And so I let her have 2 days before the baby was discharged to do what we call room in. And at that point, we didn't have a private bed nursery. And I let her stay with that baby for those 2 days, and she nursed him. And she spent that time with him, and she was able to bond. And she hugged me and cried when she had to leave and the baby was being discharged. So a year later, they had been filming a documentary at the time. A year later, I'm at the documentary preview in a town hall here at the health department. And I'm late, because I was seeing patients, and I'm running in, and I hear someone calling my name. And I look, and she is running down the hall, crying, arms open, giving me this big hug. I was so excited to see you. I have to tell you, in 2 weeks, I get my baby back. And you can't know how many times I almost wanted to quit. But the strength from the conversations and the things that we talked about and your support made all the difference in the world. And that's when it hit me. never underestimate the power of what one interaction can do. And I started talking to the nurses about this because they were, understandably, we were all dealing with a lot of emotion that was tied to this. And I talked to more and more nurses, and what I realized was, you don't know. This may be the most respect anybody has ever shown them. This may be the nicest place they've ever stayed or lived. This may be the best food they've eaten ever. And you don't know what their stories are. When we started talking to moms about their stories and you started talking about how they got where they were, of course none of them woke up and said, hey, I think I'm going to do this and go down this road. Trauma. There was such stories of trauma, of flabbergasted, being given opioids when they were really little so they would go to sleep while their mom was doing drugs or turning tricks in the other room. Afraid to get up and go to the bathroom because if I do, he's gonna see that I'm awake and he's gonna come after me and sexually abuse me. And so we had a few very open, I got into it at a high school party. Somebody had this, tub of pills and said, hey, these are safe, and that's how they got into it there. But most often it was trauma. There was some incredible trauma. So I blamed, I judged, I avoided, I felt powerless. Mainly, I felt powerless to do anything, and so I ran, right, until I was faced with it. And what I learned is, of course, we don't learn from talking, we learn from listening. And the more I listened, the more I learned. And the more the nurses listened, the more they learned. And the more we realized this is a much bigger problem. Generally we don't listen with the intent to understand, we listen with the intent to reply, right? You're sitting there and you're thinking to yourself, right? What am I gonna say? What do they want from me? You're preparing for that piece, and that's what these moms would do. They weren't listening either. Many times, to even when we came at them with compassion, they were so armed for what they thought we were going to come at them with, that it took a while to disarm them. It took a while for them to really see that we were listening, but you just had to keep at it. And Mary Coughlin's a woman who wrote Trauma-Informed Care in the NICU, and I've had the pleasure of working with her, and from a not from directly in the NICU, but working with her from other professional means. And I think this is really something that she has in one of her quotes, is it takes 40 seconds to convey compassion. 40 seconds to convey compassion, right? And so it's not really about doing the right thing, it's about being there. It's about being present in your conversation and letting that person know that you are present for them. So as I listened, I learned. As I learned, I began to understand. As I began to understand, I gained compassion. And as I began to interact from a place of compassion, everything in my world began to change. And I would see that it made a difference in other people's lives. And basically, they don't want to be here. They don't want to be here. They don't start using when they're pregnant. In most cases, I'm sure, I avoid always and never, right? But most pregnant women who don't have a substance use disorder do not develop a substance use disorder while they're pregnant. They have a substance use disorder and they find themselves pregnant. And so then they're in a world of panic and what do I do? And the system isn't built to help them because of the stigma, because of the shame. And so we really have to work to break that down. Many of them have suffered deep trauma. Sometimes it's so deep we can't even go back to the grandparents to take the baby home, and I've had great-grandparents we couldn't send the baby home because it's been so dysfunctional for so long in those families. We heard a lot about ACEs, and I think, why am I talking so much about these babies, right? because there was a point at which in my journey that I realized these babies were the tail of the tiger of the substance use disorder problem, and that this is what might get people's attention to pull their heads out of the sand and look at this a little differently, right? And so if we look at, by virtue of the fact that you're a baby in utero, you've been conceived into a situation where a mom has a substance use disorder, regardless of what place she is in her journey, that's a flag that we need to look at the home, and not from a judgmental need to take the baby away from her, from a place of what does she need? What does she need? And that's where we start getting into this whole collective impact, into the whole collaborative space, because what she needs is a team of people around her. Our communities, we heard a lot yesterday about community, right? If you don't have community around you, you're not going to succeed. If she doesn't have in her community a place where she can get safe housing, a place where she can get a job, learn some skills to get a job, where she can get help with childcare, she's not going to succeed. She's going to end up in the same situation. So we, again, big emphasis on looking at this piece of the equation in all of us, really. Mind, body, soul connection. Big emphasis on this now, right? Everybody talks about it, but where are we not putting our money where our mouth is? In healthcare. We don't pay for the alternative therapies. We don't pay for those things that can really make a difference in our physical health by attending to our behavioral and mental health. So all of this has found a NICU nurse who would have told you, I mean, I hated politics. I didn't follow, I'm confessing right here, I didn't follow anything ever. I would get to the polls and I would just vote the way my dad used to tell me to vote. And so it opened my eyes in a very, very different way. And as Judge said, at the legislature, I testified for the Safe Harbor Act. I was supposed to testify against the fetal assault law, as it was known, and was devastated because I couldn't, and my mom was dying, and I was in Pennsylvania, and I saw it had passed on the national news. And I thought, oh my God, what has happened? What is gonna happen? So I started tracking no prenatal care after that for a year, and it tripled in our patient population. Our number of micro-preemies tripled in that year because the women weren't getting prenatal care. Number of babies born in cars, in bathtubs, on the side of the road, it was unbelievable. Luckily, that sunsetted. So yeah, so one of the things I used to say was I'm not stopping until I knock on the White House door, so everybody thought that was really funny because there I was not knocking on the door, but as close as I could get. I was at a Nurses in Washington internship program. I've been able to meet several surgeon generals and many people at really high level through being on the board at the National Prescription Drug Abuse Summit, and been very inspired at the desire to tackle this problem from the highest levels. So besides that, what is my why? Is giving a voice to the 2,000 babies that we've treated, over 2,000 babies that we treated in one hospital, under one protocol, one team of people. It's giving a voice to the families, the moms, the babies, the foster families, to all of the healthcare workers, to all the social workers, to everybody that has been touched by this, which is everybody, the teachers, our workforce. It's really sharing that message to our judges, to everybody that has had to deal with this problem one way or another. For Jamma and Jim. Jamma, you might remember yesterday in the video yesterday morning, right? So I was moving. I had furniture for sale. Somebody comes to pick up a table. She says, oh, you have anything else? I said, yeah. So I take her through the house, and she says, I love that little table. I said, it was my grandmother's. We used to have tea on it. It's nothing special. It's just we used to have tea on it. And she said, oh, my granddaughter would love that. And she said, I'm taking the furniture for my grandson, but my granddaughter would love that. And something just said to me, I said, may I ask why? Are you raising your grandchildren? Yes. May I ask why? She said, well, my two of my three grandchildren were treated for NAS at Children's Hospital, and my daughter's currently awaiting sentencing. And we get into her story. We start talking. I said, what is your name? What are your grandchildren's name? The one child was one of the first babies we had through our nursery. I treated both of them. The other one, she said she's pretty certain was also exposed, but we didn't know about all of this at that time and probably went undiagnosed. The granddaughter has some learning disabilities. She's got some developmental and behavioral issues as well. The little boy seems to be doing a little bit better than the daughter, so that would be Jaylee. Jaylee has the problems, and Jace has, and Jaden are exhibiting a little more of the behavioral issues. So when I was talking to her and I told her what I was about to do, she just started to cry, and she said, thank God, somebody's trying to do something. I said, there's so many people that are trying to do something, I promise you. For her son, Kurt, who had a terrible accident, shattered everything from his waist down, was rightfully on opioids, but became addicted really quickly. Sought help, went to rehab several times. He was so judgmental of his friends that had opioid disorders and his sister that they one morning got a call. He had hung himself in their barn. He couldn't live with himself because he didn't understand why he couldn't beat it, because he thought it was a mind over matter thing. He always judged other people for that, and he was a strong person. He knew this. He didn't understand why it had so much power over him. And she said he was just tormented, and she is relieved that he's no longer tormented. Amazing people. For their daughter, Heather, who they have no idea where she is today, and they're raising her 3 kids. For these kids, who happen to be mine, who I don't know how I've been blessed to have escaped when I see it everywhere, that I have children who grew up healthy and happy and are productive. The youngest one is a sophomore here at UT. For the oldest one, who broke my heart initially because we were not a military family, and the day he told me this is what he wanted to do, why? Because, Mom, I want to make sure that kids always have a safe place to play. So there's many people here, I know, yesterday especially, that have a military background, have served our country, and to that I say thank you for your service. And we owe it to you that while you are and have been fighting for this country, from the outside threats, I can't know that he's doing that and his friends and others are doing that while I'm sitting here seeing our country fighting a losing battle from the inside. And I want to make sure that there's a place for those kids to play, but I want those kids to be healthy, and I want them to be with healthy families, and I want them to be able to grow and live and learn. So in collaboration, the first thing we have to do is seek first to understand. This is about disarming. This is about coming to these collaborative events that you're going to have in a little while and really coming at it from a place of compassion, putting agendas away, putting our prejudgments about what somebody else's sector wants from us, what we think their barriers are, what we know our barriers are, and to begin that conversation. Dr. Pack talked about that yesterday. You just sit down and start having these human conversations. We want to get a place from networking to integration, which is really where we are. It is what we do. It is our culture now. We get there through the collaborative process. And Karen Pershing had a lot on the collective impact yesterday. It's the same principles. It's the same principles. I'm not gonna, you'll have these. You do have access to this article, which is what we kind of modeled our collaborative work in the nonprofit after. And it really gives you a good understanding of the different levels of working together. And the biggest piece is that when we get to collaboration, we're talking about full sharing, full transparency. We're sharing responsibilities, we're sharing rewards, and we're coming from that common place. And we are lifting each other up within our sectors to do our best. So I'm helping remove barriers for you so that you can do your best, and we're working collaboratively so that everybody is lifted. This is just, they have access to these, I think, slides, right? So it's just kind of a simpler way of looking at it, but we really want to be collaborating now, and we want to move to integration, to a culture where we have really integrated these processes. And then we can see that it really can be transformative. We have a shared investment, a shared risk, and a shared benefit, and that's where we get to the place of really making a difference. And we're really working towards that higher good. And that's really what we saw in our task force, in our group. We started with a small bunch of people trying to solve just the problem at the hospital level. And within a month, we had people asking to be at our table. We didn't have enough room. We had to move to bigger rooms. Then we had to break it out into four different meetings with different focuses across a point of a month. So I used to say, if you build it, they will come. And I know when we were planning and they were thinking 100 people here, I said, if you build it, they will come. And you all came in droves. We have to have time, turf, and trust, right? We have to put that turf aside. We have to make the time, and we have to build the trust. And we do that with a common purpose, which we certainly have. And we bring our best competence to the table, and we are sharing motives. That means hidden agendas. You have to put those aside, right? You got to stop thinking in what am I going to get out of this, or what is my institution or my sector going to get out of this, but how can I help others? Okay. And so this is just, I think pretty much people understand the elements of trust, but we just don't always practice it. And so we really want to look at this as we are working in these cross-sectoral groups. We want to be keeping these things in mind. And as we do work going forward at a regional and community level, we want to think about this with those partners that aren't here today, that are at that grassroots level, and how we engage them and how we work together with them. Yesterday, again, in the collective impact, we talked about measurement. We have to measure what we're doing in order to know that we're making a difference. And if we're not, we have to course correct. All right, so this is where everybody stands up. We're going to test it. True. All right, but we are going to say you got to start. It all starts with a self-assessment. Part of the information that you got has in the back of that white paper is a self-assessment. And if you haven't taken it before you get into your work, I highly recommend that you do. It really, no one has to know it but you. But it helps you understand where you are in that process of being ready to collaborate. It enlightens some things that might be barriers for you that you didn't even know were barriers. So it really helps you prepare for that process. You want to figure out, where are you? Where are you on the continuum in your own mind and heart, and where do you need to be? So if we're ready, let's go. We can start collaborating. So One Tennessee, our strategic plan is to help people with that collaborative process, and to form those groups, to bring people together, to have those relationships, to facilitate those conversations, to do that work. What we hear is, look, we want to do this, but I can't get out of my, my practice long enough to do all the groundwork for this kind of thing. I can show up, but I just can't organize it and put it together. So one of the things you'll do today is you'll figure out, what is it you can do? And what is it you think you can commit to doing? It doesn't have to be anything great, big. Anything we do is going to be great. And some people may have more they feel they can do than others. Businesses might be able to offer space or food. Somebody else may be able to offer, meeting space, or I'll do all the emails, right? I mean, they're little things. They don't have to be huge, just little things. So that's the challenge. I challenge you to consider that you might be part of the problem. As much as we think we aren't. As much as we think we are open-minded. We may be part of that problem. I am obsessed with Jack Sparrow. I don't know why, because I'm sure if I was in a room with him even that far away, I wouldn't be able to stand the smell. But, I mean, if you really think about it, but this is great, right? It's not the problem that's the problem. It's your attitude about the problem. That's how we come at it, right? So step 2, believe you are a part of the solution. It's really overwhelming to think, I've been there. I remember the day that we decided we can't send these babies home with this plan. We had a great plan, found out there were all kinds of problems with sending them home. I even hate to say, to finish out their withdrawal. Extensive plans that went into place and agreements with people. It wasn't working. And we made a decision one day that we were going to not send these babies home to withdraw. We were going to keep them until they were healthy enough to go home and off medication. We weren't going to send them home with people trying to deal with what we were struggling to deal with when people worked 12 hours and had breaks and were able to go home and not deal with it. So we had 12 patients in the nursery at the time who thought they were getting to go home at some point soon. And we had to walk into that nursery. We struggled with, how are we going to phase this in? How are we going to do this? And we just decided we'd jump. We walked in and said, we collectively, as a practice in a hospital, have decided through the research that this is not a safe practice. And we are going to change our practice. And we know you may have been told you're going home tomorrow. You may have been told you're going home in a week or two. Your baby will be here until your baby is through withdrawal. That was a really big thing to do. You can imagine the fallout of that. But it wasn't as bad as we thought. I've worked with the chronic pain guidelines, and talk about a collaborative group, have discussions, people come at it with their points of view, they're very passionate. Sometimes it gets a little heated, but nothing really too bad. Everybody goes to lunch and comes back, and usually you'll hear the conversation, man, I really started thinking about that differently, and I see your point. I have been floored with the work that has come out of this group. Difficult decisions about changing what happened last year, July 1, with prescribing practices. big decision, concerns about the fallout, but at some point, you have to do what's right. You have to do what you know. All right, we'll just skip that. I'm tongue-tied. We have to think outside the box. I love Albert Einstein, and we can't come at, especially from healthcare, but I would assume it's probably correct in any sector. We cannot come at this problem thinking the same way about it that we always have. From an institution, not just from a personal, but an institutional level, et cetera. We've got to start thinking outside the box. And if there's ever a time, I'm convinced, that the climate is right to change how we practice healthcare, it's now. I think anything, solid idea that might get out there could stick. And then the next thing we have to do really is we have to find ways to make the right thing to do the easy thing to do. A very good friend of mine, Judge, tells me all the time, just do the next right thing. And then do the next right thing. And I think that's what we have to look at. This is a massive problem. It is overwhelming. How do you eat an elephant but one bite at a time? So what if we're all taking one bite out of the elephant together? We're going to make much greater progress. But we focus on what is the right thing we need to do, and then we start working together about how are we going to get there, right? So it could be big gaps. We know that it's right, that we need to start utilizing other types of medicine in our practices, acupuncture, some Eastern type influences, right? But how do we do that when it's not paid for? Well, we gotta problem solve those things. We gotta make that jump. We gotta start looking at it very differently. The biggest obstacle is giving up. It's being afraid and giving up. And we can't do that. There are too many people. And I'm telling you, the next generation is not just the NAS babies, it's the massive number of babies that have been drug exposed that we don't know what their risks are going forward. We have reason to suspect certain things, that they may have a higher incidence of substance use disorder. If for no other reason, then more than likely they had a high ACE score, which puts them at great risk for substance use disorder. So when people want to argue with me about, you can't know that this drug or that drug or this or that, I'm like, okay, fine. Just look at what their ACE scores are, where they're coming from. So we have to really look at this very, very differently. And then come together and we think collectively we can start to bridge those gaps. So my challenge also, especially in the healthcare industry, is really, I think it is time. The time is now. We have got to make mental health the first vital sign. I used to say, oh, pain is the fifth vital sign. This is the risk assessment is the sixth vital sign. Mental health assessment, risk, and as a colleague of mine were discussing recently, she added resiliency, risk and resiliency, because my ACE scores weren't great. So how did I escape? And if I look at the factors that gave me resiliency, I think that's the key. And so we have to, again, if we focus on moving towards, at a community level, supporting, as a community, these women, imagine the impact. Imagine the impact if you're a child and you see your mom being drug off by the cops, right? And DCS comes and gets you. That's your mom. It doesn't matter. She's got a needle in her hand. That's your mom. Imagine the impact if you see your mom struggling and somebody comes and gives her a hand and somebody says, hey, I know this is tough, but we're going to do everything we can to help your mom and help you guys be the best family you can be. We got you. Imagine the power of that. So, a drop of water. That's what we are, right? We're just drops of water. And so what kind of power really does it have? Maybe a ripple effect when you see a drop hit the pond, right? You see a ripple effect, and yeah, we could do that. But look at that wave. What's it made of? Drops of water. Look at the power of that wave. All made up of single drops of water. It wouldn't be that wave without the single drops of water. So, my challenge to you is to look inside as we go forward the rest of the day and think about how you're going to approach this problem. Think about your takeaways. What can you do? Who in your communities can you engage? Start with one person. You don't have to fill the whole team. Go back and say, hey, will you join me in this? Can we get a group together for our community, a cross-sectoral group for our community? Who do you think would be interested? One person at a time. Start those meetings. We heard about that yesterday. Have the meeting. Schedule the meetings. Just keep coming. Maybe you don't know how you're going to go, navigate through it. In a year, we may have a nice little roadmap as All for Knox tests out their program. We may find that there's a roadmap we can use that'll make it a little bit easier. We're hoping to be able to hold some meetings following this that will help reignite these issues that we're talking about today, to bring that information to people who weren't able to make it here today, across the state at regional and community levels. So think about your takeaways and think about what you can do. And thank you for listening.